Thank you so much for inviting us to present some of our reports that we have collaborated with several of you who are in attendance. And this is, I know there's been a lot of talk about neurocognitive dysfunction in these patients, but from a clinical perspective, we try to assess to our best of our abilities with everyone the cardiac manifestations in a larger pool in these patients. So I'll be talking about the association with congenital heart disease and particularly arrhythmias. I'm a clinical cardiac electrophysiology fellow at Stanford, so I'm particularly interested in arrhythmias or the electrical system of the heart and how that can be a problem in these patients. So we don't have any relevant disclosures for this project. This group knows better than anybody else out there about Kleefstra syndrome and EHMT mutation and haploinsufficiency that can cause often diagnosed in early childhood, is characterized by neurodevelopmental cognitive dysfunction with specific characteristic facial features. And in terms of congenital heart defects, there have been reports in case series ranging anywhere from 10 to 50% of the patient population. So it's not completely new. And Dr. Kleefstra and several others have reported this. And these defects have primarily been reported to be ASD, atrial septal defects or ventricular septal defects, a few reports of aortic coarctation, bicuspid aortic valve, pulmonary valve stenosis, patent persistent foraminal PDA, patent ductus arteriosus, as well as conotruncal cardiac defects, including tetralogy of Fallot and transposition. And these are mostly individual isolated case reports of that. And there have also been some reports of aberrant muscle bundle potential in a left ventricle and a hypoplastic left heart and pulmonary hypertension. So a wide variety of congenital heart defects have been reported. And as everyone here knows about EHMT1, I'm trying, in terms of what it means for a cardiac cell, there have been studies to show that the gene itself modulates several other genes that regulate cardiomyocyte cell cycle and maturation, especially from a neonatal to an adult state through post-translational histone modifications. And there have been not many, but one or two animal studies that have linked to EHMT1 to congenital malformations, primarily of the atrioventricular septum, so that those atrial septal defects and ventricular septal defects are explained to some extent by these studies, but not everything else. And interestingly, suppression of the EHMT1 gene was linked to pathological hypertrophy of the ventricle, particularly the left ventricle, and preferential proliferation of the immature, the neonatal aspect of the cells, not the mature adult type cardiac cells, which is often what we find in iPS cell culture. So again, some evidence to show that there could be a problem there, but not a direct link to clinical phenotype. And there has been one patient who was an 11-year-old girl with neurodevelopmental delay, whose iPS-derived neural cells had shown altered morphology and cholinergic dysfunction. And the current recommendations from a cardiac workup standpoint, as you've seen, is mostly reports of congenital structural heart defects, primarily of the septal defects. So there is most patients do get some kind of cardiac imaging, such as echocardiography, but not all the patients do that, and it's not routinely recommended. But all the patients do seem to get a baseline EKG once the Kleefstra syndrome diagnosis has been established, but there's no routine monitoring recommended for these patients. Our case was actually inspired, my interest in this work was first inspired by a 27-year-old man that we saw here who carried a diagnosis of Kleefstra syndrome and who actually had atrial fibrillation. Hence, that's the reason we had seen him, with a very rapid ventricular response, which was first diagnosed when he was 23 years old. And for 4 years, several attempts were made to control this with all sorts of medications, including beta blockers and sotalol. And despite that, it was just poorly controlled, and his heart function was slowly deteriorating, and his symptoms were getting worse, which included palpitations and fatigue. So at which point we decided that we would take him to the EP lab and do our procedure where we would to an AFib ablation, which was in his case a simple one because there were triggers in the pulmonary veins that we could ablate. And since then, he hasn't had any more AFib, and his cardiac function had fully recovered, which also represents the first case of an AFib ablation in such a young patient with Kleefstra syndrome. But the procedure itself was, nothing interesting to talk about. But what's interesting is this patient who exhibited the classical KS features had firmly established diagnosis of Kleefstra syndrome with EHMT1 haploinsufficiency, had no baseline structural congenital heart disease on echo or cardiac MRI. There was not even gadolinium enhancement on the cardiac MRI. So this, if you had not seen this patient and you had not known about his Kleefstra genetic testing, you would have thought that this was a young 27-year-old with no cardiac problem just from his imaging or EKG, which looks perfectly normal for most patients. That would not suggest that he has any arrhythmias to talk about. But why would he have atrial fibrillation that was so detrimental? So that could not be explained. We also ruled out other potential reversible causes, including thyroid and electrolytes. There were no other really risk factors, but he did have, as has mentioned before, some sleep disorder, breathing and sleep apnea, which may be also due to his Kleefstra syndrome. He was a fairly thin young patient who was at the time fairly active too. And it's been more than 16 months now. It's close to 20 months now, and he has not had any more atrial fibrillation since then. And since this report, most of this work that I'm presenting today has yet to be published. We're currently in the very final stages of submitting this work for publication. We have had 2 other young patients, physicians reach out to us with Kleefstra syndrome where arrhythmias were also identified. One had a diagnosed atrial fibrillation at the age of 25 during a visit to the dentist, also without any structural congenital heart disease on echocardiography at Boston Children's. And then there was an unstable atrial tachycardia in a 17-year-old who was admitted there at Johns Hopkins. And again, interesting point to take home here, the very young patients who do not have structural heart disease on imaging. And both these patients were medically managed with metoprolol, atenolol, and amiodarone. Further information for our Stanford patient here. So this was ambulatory monitoring proving atrial fibrillation that was going very fast, as well as atrial flutter. So this I wanted to include to show not only to prove the arrhythmias themselves, but also that this is routinely done in our practice where we have now several methods of outpatient monitoring of cardiac rhythm, including patches. So this was a Zio patch, but you have many other varieties now that are very cheap to very expensive that are very easy to do. You can do this at home, and this patient had one of these things, and you had all this readouts of quite a bit of summary, including how much burden of atrial fibrillation, how long did it last, did they have other ectopic beats in the atrium or the ventricle, So this adds the whole new angle of potentially AI in cardiac rhythm monitoring for these patients at the convenience of their own homes. And also, as the wearable technology progresses, it's getting cheaper and more accessible. So this then asks the question, is this a one-off thing? And maybe now we have talked about 3 potential cases. Is this a more systemic consideration that Kleefstra syndrome may have some arrhythmia associations with it, other than just structural heart disease? So, with collaborating with Radboud UMC and Janita, collaborators, we looked at both of those registries, which are the 2 largest that we are aware of, just to look at this. And as many of you know, Radboud University is in Netherlands. It's purely, it's very high quality data with patients and their medical records screened by, very medically trained personnel. So this data is very robust. And the Janita registry, as everyone's familiar with, is more of a participatory patient and family given information. So, and this is available in 7 languages and is aimed at compiling the genotype and phenotype of multiple neurodevelopmental disorders, of which Kleefstra syndrome had 163 patients. On the right here, you see the table of the entire worldwide distribution of the Kleefstra syndrome patients currently in the genital registry, most of whom are in the US, UK, France, Germany. Now, the Radboud registries obviously is in the Netherlands. There's 4 patients here in the Netherlands. You'll recognize there's 50 from this registry that were included here. So it's possible, but we're not sure if these 4 are overlapped. It's based on the information that we saw, they were not overlapping because the information did not match. Now, the congenital heart disease in both these registries, that's the first thing we looked at with, again, Radboud UMC 50, Geneta 163, median age was 13 and 10. Radboud UMC had a less, like 38% male, 62% female. Geneta was more equal distribution. About 40% in both registries reported some abnormality of the cardiovascular system. From a cardiologist perspective, what is an abnormality of the cardiovascular system? It's a very generic term for us. But for an arrhythmia, about 8% is actually very similar percentage between the both have reported some arrhythmia, which is not trivial. 2 patients with Geneta reported cardiomyopathy. Now, ventricular septal morphological defects about 10 to 12%. Now, atrial septal defects and ventricular septal defects were the previously most predominant in the smaller case series. So again, so you have about 10 to 15% in both these registries have individually atrial septal defects or ventricular septal defects. So, and tetralogy of Fallot, 2 patients in the Radboud UMC, patent foraminal 2, about 5.5% of patients with a PDA. But now, looking at the other valvular diseases, you look pulmonary valve stenosis, 2 patients and 14 patients, so about 4 to 9% in the registries. Bicuspid aortic valve and aortic valve stenosis, 7 in the, about 5% in Geneta. Mitral insufficiency, about 3 to 4%. And abnormality of the greater vasculature, which includes it's a bucket of the entire conotruncal defects and others, including transposition. Now, they are rare enough to begin with, but not quite so rare in this syndrome, with Geneta having about 9% of patients with some form of abnormality of greater vasculature. So with this more, this represents the largest registry, and we have more of a granular idea of the types of congenital defects that may be found in these patients and their prevalences. Now, my focus is the arrhythmias now. So with this congenital information in hand, how did the arrhythmias look like? And in Radboud UMC, we had 1 patient with paroxysmal AFib treated medically, found at age 25, no structural heart disease. 1 patient with supraventricular tachycardia who had an ablation and verapamil. Now, this is SVT, which we're not sure exactly what type of SVT, but but pathway-based SVT would not be uncommon in the young population. Pediatric electrophysiologists deal with it all the time, so it may not be as specific to Kleefstra. Again, diagnosed at age 18, paroxysmal SVT, but this was accelerated nodal rhythm, again, age 23. Non-sustained ventricular tachycardia treated just with monitoring and expectative management at age 22. Structural heart disease-wise, there was some mild mitral valve insufficiency reported, but again, technically, one could claim this is structural heart disease, but clinically speaking, the ejection fraction was normal, and the insufficiency in the mitral valve is normal, and that would not be considered clinically relevant. So technically, from a clinical standpoint, that is not contributing to the arrhythmia. Now, Geneta had 2 patients with atrial tachyarrhythmias, one with atrial fibrillation, one with atrial ectopic tachycardia, which is in the same spectrum as atrial fibrillation. Both of these patients also very young, as you would expect. This is our patient at Stanford, paroxysmal AFib, atrial flutter, premature ventricular contractions, as well as non-sustained ventricular tachycardia. We report the first case of pulmonary vein isolation ablation in this patient that was successful at age 23 was the diagnosis. He underwent the procedure at age 27. The Harvard patient at Boston Children's had paroxysmal AFib, incidentally found at the dentist's office. Johns Hopkins, we talked about with the atrial tachycardia. Again, also young patients with no structural heart disease on imaging. So it's taken together, as you can see, there's quite a lot of atrial tachyarrhythmias in this very young population that you would not otherwise expect to have this problem. This is something, atrial fibrillation is something that we expect for, in the older aging group. You know, it's almost the, we tend to think of it as a myopathy that progresses over time. Usually, even a 60-year-old in most of the AFib trials is considered a young patient. So this is very unusual, to say the least. And the limitations, it is a rare condition with a limited available information, but we did do our best with our collaborators to really thoroughly look at the registry data and what's available. And despite best efforts, not every KS patient might be captured here. And again, it's important to recognize that these registries are not aimed to target cardiac concerns, although we are carefully evaluating. And in the GenEater registry, as we said, does not have a thorough medical record review. And not all the patients got imaging or rhythm monitoring, although most that we are reporting, especially with arrhythmias, did, except for 2 patients in the GenEater registry that we don't know. And there could be a selection bias because the 3 cases that I specifically reported that we do know with arrhythmias here, they were sent to us, so there is a selection bias. We will only be told about patients who've had arrhythmias. That being said, it still proves that this arrhythmia is occurring in a very young population that we would not have expected to have this without structural heart disease. So in conclusion, in this large registries, as well as our cases, I think we see that there's a high prevalence of congenital structural heart disease, 40% as expected, but also we've defined the prevalence of more subtypes of these congenital disease, structural heart disease that you can expect in this population. But also importantly, that there's these early onset atrial tachyarrhythmias, and they were mostly found incidentally, you know, and it's important to know because this is not a population that would probably easily explain to you that they, or even the physicians diagnosing them would consider this as a potential in their differential diagnosis because this is not expected. So it's important to consider that. And we report the first successful case of an AFib ablation without recurrence. And as I said multiple times, these are arrhythmias without structural heart disease that we found, which, so we have at least 4 young patients, 3 atrial fibrillation, 1 AT without structural heart disease. So, which begs the question, is there the possibility of a novel epigenetic mechanism for AFib that we need to further study mechanistically, possibly with iPS cells? We're not sure, but that's what the next steps may include. And as you know, unique challenges and barriers for patients to communicate the symptomatology in this population. So for this patient population, routine ambulatory rhythm monitoring as with variables that are becoming easier to access and cheaper with AI may actually be beneficial, but that is yet to be determined. In addition, our specific patient, when we did the AFib ablation, I had shown a picture earlier where we did mapping electrically inside his heart. And the voltage that we normally get, electrically speaking too, everything looked absolutely normal. So, you know, at least at the resolution of our cardiac imaging, as well as our endocardial mapping, where we're pretty much touching all the different parts of his heart from the inside and getting electrical parameters, is very, it looks normal from our viewpoint, our vantage point. So there may be more at a more granular level, at a cellular level, that there could potentially have a mechanism that we're not understanding. I want to really thank everyone that was involved to help us with this and to provide some of these insights, including Tanja, Ariane, Joost, Matt, Chloe, Siddharth, Jacqueline, Paul Fisher, Paul Wong, Nitesh Badwar, and especially big thank you to Dr. Kleefstra and Dr. Perez, who's my mentor through this project. I want to acknowledge some of our clinical geneticists and collaborators and nursing staff here, including Jennifer, Colleen, and Allison. Thank you, everyone. Thank you for this opportunity.